So first off, could you just explain what the PLCOm2012 model is and how it was developed?
The PLCOm2012 lung cancer risk prediction model is a model that estimates an individual's risk of lung cancer, developing lung cancer, over the next 6 years. And it was developed by data from the prostate, lung, colorectal, and ovarian cancer screening trial, also known as the PLCO trial. It was a very large US trial with over 150,000 participants. And it was a very high quality follow-up and measurement of predictors and lung cancer outcomes. It was roughly representative of the United States population, and most people between the ages of 55 and 74 were eligible for enrollment. And the PLCO 2012 model has been widely validated in by multiple researchers in many countries, including the United States, Canada, the UK, Germany, Australia, and Brazil. And not only has it been validated in many studies and by many researchers, it is also currently being used for eligibility criteria in the screening programs developed in Ontario, Canada, and in the National Health Services in the United Kingdom. What I think is really interesting about the PLCO 2012 risk model is that it is unique because it has 11 different risk predictors, much more than age and smoking history that the current USPSTF guidelines are based on. Besides age, there are 4 different smoking variables. They have the duration of smoking, how many years a person smoked, the intensity of smoking, how many cigarettes per day, smoking status, if the patient is current or former, and how many years ago a person quit if they were a former smoker. But it also includes other very important predictors, and includes race. And we know that after adjusting for age and smoking, race is a risk factor, particularly in African Americans. It also includes a history of COPD, a family history of lung cancer, a personal history of cancer, BMI, and level of education. So all of those predictors go into a risk stratification tool, and it gives you a score of an individual's risk for developing lung cancer over the next 6 years.
So thank you for explaining that. Could you now also explain the recent study of the model?
Yes. So what we did is we know that race disparities exist in lung cancer outcomes. And the current United States Preventive Task Force, the USPSTF lung cancer screening guidelines, their eligibility criteria is solely based off of age and smoking history. You have to be between the ages of 55 and 80, a current smoker or a former smoker who quit within the last 15 years, and you have to have a smoking history of 30 pack years or more. And 30 pack years is smoking 1 pack a day for 30 years. So it's a very heavy smoking history. And African American ever smokers have the highest incidence and mortality from lung cancer, even though they typically smoke fewer cigarettes per day compared to white smokers. And they often won't meet that 30-year cutoff to be screened for lung cancer, even though they are very high risk. So the current USPS criteria may exacerbate racial disparities because it underselects African American ever smokers. So the objectives of our study was to compare the sensitivity of 2 different screening criteria, the PLCOm2012 risk prediction model and the USPSTF. And we evaluated whether the PLCO2012 model would more effectively select high-risk African American ever smokers for screening. So what we did is we took these 2 models and we retrospectively applied them to a large case series of smoking-related lung cancer cases from an urban academic medical center in Chicago, which primarily serves minority populations. And out of our case study, we had 883 lung cancer cases in our study. 56% were African American and 29% were white. And what we found, we compared the USPSTF criteria to the PLCO 2012 model. And what we found is the PLCO 2012 had increased sensitivity to select African American ever smokers. We studied the sensitivity of the PLCO 2012 using 3 different risk thresholds at 1.51%, 1.7%, and 2%. And we found that the PLCO 2000 risk model was more sensitive in identifying African American cases at all 3 of these thresholds. And for example, at the 1.7% risk, the PLCO 2012 model identified 71% of the African American cases, where the USPSTF criteria only identified 50%. So that was significant. We also found that both the USPSTF and the PLCO 2012 model were both able to identify high-risk white individuals. Then what we did is we looked at, we wanted to evaluate the ability for the PLCO 2012 model to select individuals that were ineligible for screening under the current USPSTF criteria. Those that were younger than age 55, less than a 30-pack year smoking history, or had a quit time of over 15 years, making them ineligible for current guidelines. And what we found is 45% of the cases in our high-risk lung cancer cohort were USPSTF ineligible. And of these, 36% of them would have been eligible if they were screened using the PLCO 2012 model at the 1.7% risk threshold. So overall, the PLCO 2012 model we found to be more sensitive than the USPSTF criteria at identifying African American ever smokers for lung cancer screening. And we feel that a broader use of this model, and particularly in racially diverse populations, may help overcome those disparities in lung cancer screening and lung cancer outcomes.
So what was the inspiration behind this study?
So we serve primarily individuals with lung cancer and lung cancer screening from high-risk communities, low socioeconomic minority communities. And currently the USPSTF lung cancer screening is based off of age and smoking, as I said, and doesn't include a risk stratification model. And our study shows that this model is more sensitive in identifying high-risk individuals, particularly African Americans. And what is important about the USPSTF lung cancer screening guidelines is that recommendation is a grade B recommendation. And any grade A or grade B USPSTF recommendation for preventative screening makes it that it is required that private insurance companies pay and cover the cost without any cost sharing for the screening. So the patient can get screened without having co-pays, deductibles, or co-insurance, and this is under the Affordable Care Act. So eliminating this financial barrier is very important when you're working with patients from low socioeconomic communities. It's very important. So the USPSTF is in the process of updating their lung cancer screening guidelines and incorporating this, the PLCO 2012 risk model into the USPSTF criteria will assist with risk stratification for lung cancer screening and decrease risk disparities. Before a patient gets screened for lung cancer screening with low-dose CT, they should have what we call a shared decision-making visit, which is a conversation between the patient and the provider. And this is Medicare mandated for lung cancer screening. And it's important to understand an individual's risk and benefits of screening. And by using the PLCO 2012 model, this can help guide the conversations to talk to that patient about their individual risk for lung cancer and to determine if the patient should be screened for lung cancer.
So are there any sort of next steps that are planned for the study?
Yeah, we have quite a few next steps. This was actually a second study. We already did one study before that was published in 2018 in JAMA Oncology, where we found that our lung cancer screened patients in this population had 2.5 times the amount of lung cancer diagnosed compared to the National Lung Screening Trial, which comprised of mainly 91% white and only 4.5% African Americans. So that gave us the ability and that we wanted to go back and start looking at the lung cancer population and to see about applying this risk model to that population. So as far as next steps for the study, yes, we are now reanalyzing our data and applying them to the new USPS draft guidelines. And we're looking to evaluate disparities related to gender and socioeconomic circumstance within lung cancer and lung cancer screening. In addition, we're also planning to repeat and expand our study into different populations. And the most important thing is we want to improve the knowledge and better understand lung cancer health disparities and how we can work to eliminate them.
So until a screening model such as this one is being used in clinical practice regularly, how can African American patients advocate for themselves with regard to lung cancer screening?
It's important for all individuals to understand their own health risks. This is a great conversation to have with their healthcare provider to assist patients to understand their risk. Some cancer risk factors are modifiable, such as smoking, and there's many great resources to help people stop smoking. Primary care physicians should be screening their patients for lung cancer, just like they do for breast cancer, colon cancer, or cervical cancer. And patients can be their own advocates by talking to their own their primary care provider, bringing it up to them if they know that they're high risk. And lung cancer screening programs are being established throughout the country, and every high-risk individual should be offered lung cancer screening. I do want to say that the PLCO2012 risk prediction model is easy to use. It can be downloaded from the internet. Lung screener navigators can effectively use this model to screen candidates for lung cancer screening. It's being developed in an app and on a tablet to make it easier for practitioners or patients to use. And since most of the risk predictors in this model are clinical, they are also collected in the electronic medical record. So in the future, it would even be available to have the risk prediction model incorporated in the EMR.
Great. So what sort of resources exist that African American patients can turn to better understand these disparities in lung cancer screening and how to combat them?
So there's many disparities in lung cancer. Tobacco companies target minorities and low socioeconomic communities. Tobacco disproportionately affects many of the marginalized populations, including people from low socioeconomic communities. And there's a lot of resources on the internet to get help to quit smoking. There's also many other organizations that are assisting patients with lung cancer screening and lung cancer resources, such as the American Cancer Society and the American Lung Association and the Go-To Foundation, to name a few. These organizations have very valuable educational content on lung cancer and lung cancer screening and can assist patients to find a screening facility close to them in their area where they live.
Great. So that's all I have for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
Yeah, so it's really important to understand that the majority of lung cancers are unfortunately diagnosed at a late stage, stage 3 or 4, which have a very low 5-year survival rate. This is because by the time an individual develops symptoms and sees a doctor, the cancer has already spread to a late stage. And lung cancer screening has the potential to save a lot of lives. By diagnosing lung cancer at an early stage before the person has symptoms, when it's curable and treatable. And it's important that all high-risk individuals get screened or have the opportunity to get screened for lung cancer. And using the PLCO2012 model is an important tool to discuss lung cancer risk with your patients. Our study shows the importance that this model is able to identify high-risk individuals that would not meet the USPSTF criteria. And it would be a valuable tool for the USPSTF task force to incorporate in their new lung cancer screening guidelines to evaluate individuals' risk for lung cancer during that shared decision-making visit. This will improve health outcomes and decrease health disparities in lung cancer and lung cancer screening. I thank you for this opportunity.
Absolutely. Well, thank you so much for taking the time to speak with me. I really do appreciate it.